So okay, welcome back and good afternoon or almost afternoon. Good late morning, everyone. I'm very happy to introduce our next two speakers. First, because I personally find their two professions fascinating, nurse and midwife. Two professions that I considered doing myself, but I didn't for other reasons. But second, because after speaking to both of them, I really see how their professions and the programs they were able to implement in the healthcare and the workforce really tie into how creativity does have a place in healthcare. So I'm happy to hear more about what you have to say as well. We'll start with Bryn. So Bryn McNamee-Tweed was raised in North Carolina before graduating from Dickinson College in 2011 with a Bachelor in Arts in Global Health. After working as a community health worker at the Mexican consulate, she went to New York University earning a Bachelor of Science in Nursing. She then joined Morgan Stanley Children's Hospital, New York Presbyterian, Columbia University Medical Center as a registered nurse at the neonatal intensive care unit. After nearly 4 years in the NICU, she moved to Ann Arbor, Michigan to complete a master's degree as an advanced practice registered nurse, specializing in nurse midwifery at the University of Michigan. Bryn graduated and later became licensed as a certified nurse midwife in 2019 before joining a large obstetrics and gynecology practice in Morristown, New Jersey. She provided full-scope healthcare for women of all ages, including prenatal and postpartum care, labor and delivery. After several years in private practice, Bryn returned to Columbia University in a different capacity as the clinical coordinator of the neonatal comfort care program.
Hi, like she said, I'm Bryn. I am a perinatal palliative midwife and the clinical coordinator of the neonatal comfort care program. So the neonatal comfort care program started by Dr. Paravicini about 15 years ago. And we walk through pregnancy and delivery and postpartum care with families that are facing babies with life-limiting illnesses. So we provide perinatal palliative care that is defined by ACOG as a coordinated care strategy that comprises options for obstetric and newborn care that include a focus on maximizing quality of life and comfort for newborns with a variety of conditions considered to be life-limiting in early infancy. So most of the time, you see midwives in this capacity, where they're in homes, delivering in tubs. They are low intervention. It's about interpersonal relationships, or you see a TV show, which is how many people interact with them and tell me all the time. And this is sort of the more historical representation of it. But now in the US, the majority of midwives actually work in hospitals, the vast, vast majority. We have a really broad scope of practice, and I do, when I was doing gynecology, preventative cancer screenings, and then also mental health care on the postpartum side. So we have incredibly large scopes that also includes the care of the newborn up to the first 60 days of life. So midwives have always been associated with birth and life. However, I would really argue that in my capacity as a midwife in the neonatal comfort care program, I also work and care about life. These lives are going to be shorter than parents hope for, and certainly we hope for. But what's important to us is that those lives reflect the values of their families and are meaningful in whatever capacity for however long they live. When I went to midwifery school, in a very weird way, I went with the idea of doing palliative care. So I was lucky enough that at each sort of interval of learning, I was able to interrogate the sort of midwifery care with the ideas behind palliative care and how that might sort of be intertwined. And I continue to do that. So both disciplines, midwifery and palliative care, are characterized by patient advocates, thoughtful clinicians, superior communicators, and really high levels of emotional intelligence. So this is a chart by Van Hoover and Holt from 2016 that compares midwifery and palliative care, and I'm just going to point out two of them. So the first one is advocacy of non-intervention in normal processes. So for midwifery, that looks like letting women's bodies do what they're made to do, have babies, have hands off, don't do anything unless you need to. And for palliative care, that also means using technology judiciously and using it towards healing rather than causing suffering. So both of those really align again. The second thing I want to point out to you is modifying for medicalized rituals in order to meet the best needs of their parents, of their patients. So again, these are identical. And I think sometimes people see our program or see us and think it's about that we break rules or we do what we have too many people in a room or they stay too long. And to me, it's not about breaking rules. It's about what is the best medicine. And the best medicine doesn't always look like IVs or epidurals. It looks different. And that's the kind of medicine that we practice. And I think that my combination of midwifery and palliative care sort of is that beautiful unifier. So as a perinatal palliative midwife, the scope of midwifery care, as determined by the American College of Nurse Midwives, which is the governing body in the US, basically described that the education should include palliative care, first off. And second off, that the scope of my care is for palliative care for conditions incompatible with life, including addressing the psychosocial needs of a grieving parent. Now, we don't love some of the language in that sentence. We don't use incompatible with life. That is incompatible with how we think about what we do. But this explicitly states that midwifery and palliative care are entwined and natural. So, a couple of the core actions of what I do. The first one is direct clinical care. So, I work in the antepartum space. We meet moms at 20-ish weeks of pregnancy whenever they get that diagnosis that's life-limiting. We continue with them. We have several meetings with them before they deliver, which I'll talk about. And some of those are just trust building, some of those are gathering information, some of those are birth planning. I don't know what's happening. Do you hear the noise? No. I hear. There's like a song or something. I saw it was iTunes. I got it. I don't know why. We're gonna like rage out in here. Okay, so clinical care, intrapartum, I'm in the delivery room. In my capacity, I'm not actually doing the delivery because in a very comical way, New York Presbyterian are like over sort of branching, doesn't allow midwives to do deliveries. New York City is actually a little bit behind the times, surprisingly. So we're in the process of continuing that sort of like step-by-step of getting me to be able to actually deliver our patients. But now, basically, we catch the babies. They deliver the baby and immediately hand them to us. I specifically do postpartum care, neonatal care, and then bereavement care. So again, huge scope of practice. In probably the most important thing that I think makes my role specifically special and our program special is continuity of care. So this can be broken down in a couple different ways. The first one is relational continuity. So from the time that I meet mom, I'm having regular interactions with her, whether that's like text messages or I go and meet her in person. She comes in person and we talk through her choices again. But it is about this really robust establishing of relationships before she even delivers. Informational continuity is us trying to have one voice. So subspecialists, so we have, hematology in one corner and ped surgery in another corner, and everyone has a say about what should happen to the baby. And we try to sort of unify recommendations and provide this sort of one voice. So mom is getting information that sounds like what she's hearing from everyone else, and that makes it less overwhelming for them when they're getting a million different voices telling them different things. It's really, really overwhelming. So we try to homogenize that. And then management continuity. So I'm aware of every appointment that she has, when she's coming in, who she's seen, who she hasn't seen, who she would like to see. So again, we're sort of managing all the details of her life as well to make it as easy as possible. A big one is intervention counseling. So in our very first consult with the family, Dr. Paravicini is sort of going through this diagnosis in detail. So giving people an idea of what the actual diagnosis is, what that would look like in real life once a baby is born, giving an idea of if we did full intervention, if we threw everything at this baby to try to heal them, to cure them, what would that look like? And do we think that would likely be successful? We explore comfort care, meaning that we don't provide the same kinds of medical interventions, aggressive curative therapies. We're offering different kinds of interventions that prioritize baby's comfort, so we can use medicine to make sure that they're comfortable, that they're pain-free. We can do little things in between those two. So if they want a little bit of a nasal cannula because it makes them feel like they're doing something, great, let's put a nasal cannula on. If they want us to intubate but they don't want us to do chest compressions, we can also do that. So it's not all or nothing. It doesn't all look the same. Comfort care looks different for every single person, and that's why my role is really important, because we can talk about the specifics of being pregnant, delivering, and then also the neonatal care. The next thing is anticipatory guidance. So I don't know if you've ever seen a baby die, but they're, like in adults, are often sounds that can be disconcerting to parents. That can be gasping, that can be gurgling, that can look lots of different ways. And so a major thing that we try to do, that doesn't usually happen in those prenatal consults, it usually happens in the delivery room, that we'll walk people through, this is what your baby might look like, this is what they might sound like, this is what they might smell like if they've been passed away for a long time in utero. So we try to give them really concrete information so that when they're having a reaction, they're having an emotional reaction, but that emotional reaction is grounded in a little bit more of reality and not just this nebulous idea of all the terrible things that are running through your mind that you think you've heard. We try to put a little bit more detail so that the scariness and the intimidation is more controlled. It's not eliminated, but it's controlled. And then we also do advanced care planning. So I'm sure a lot of you have done advanced care planning, either for loved ones or in your role, and that looks like wills and things like that. It looks different with babies. So we call it a birth plan. And the birth plan is very specific, and we make this with the families once that relationship has already been established. So we've seen them multiple times, we have had multiple interactions with them, and we are trying to put on a piece of paper that we will put in the chart, the electronic records, that is an expression of their values. We are trying to translate what's most important to them onto a piece of paper so that if we are not there right away, other clinicians can look in the chart and see, oh, this is what they want done. So that can include things like, do you want the baby to go to your chest right away? Does dad want to cut the cord? Do they want to do a bath? What kinds of sort of resuscitation efforts they prefer? So it, again, details. Because I think one of the hardest things about being pregnant with a baby that we don't know how long is going to live is the unknown. And being able to help them put a little bit more detail to their fears can be really, really helpful in coping and managing the fear of the situation and the sort of dread, ultimately. So I think it's helpful to think about my job in a framework of a term coined by Paul Farmer, who is a physician who unfortunately passed away, that was at Brigham and Women's leading the Department of Global Health Equity, and he also is the founder of Partners in Health. He is really like a hero of mine, and he came up with this idea about expert mercy. And this applies as a framework through which midwives uniquely practice palliative care. So the term describes an approach to healthcare in the original form that's comprehensive and focused more than just on clinical excellence. That Dr. Farmer invites us to consider that the benefits of our medical expertise can only truly be reaped when we practice mercy as well. And in this setting, mercy is not charity. We're not doing it just out of the goodness of our hearts. It is a thoughtful and informed method of facilitating the benefits of this expertise. So we can manage a patient clinically with medicine. We're going to manage their terminal dyspnea. And also, we're going to offer memory making and sibling visits. And those two things go hand in hand and enhance the coping for both of them. The terminal dyspnea we can manage so that then those sibling visits are going to be moments of joy, not moments where you're trying to manage this sort of scary sounds that are coming. So a couple examples are clinical expertise, pharmacologic, advanced care planning, and then in Mercy, it looks like tools to facilitate wellness, memory making, and then emotional intelligence. So Expert Mercy really represents the particular strengths of midwifery, this emphasis on providing both clinical and non-clinical skills that sees patients as whole beings, multifaceted, complicated individuals, and we are doing our very best to attend to all of those complexities. All right, so I'm going to tell you about two of our sweet families. This is the Fowler family. These are baby Chloe's sweet feet that have just been dunked in ink, so that's why they're black. So mom was admitted to antepartum around 31 weeks. She had no fluid, and the baby had been diagnosed with bilateral renal agenesis. This had been diagnosed at an outside hospital, and she had come in. So she was alone. Her husband was working 2 hours away. So she had come, was all by herself. And we built a relationship. So I went in and we had a very brief interaction. Nothing of substance was really talked about, just sort of the logistics of her life. And then we went back and had a full consult with Dr. Paravicini. And we walked her through the options that she had in front of her. She could do comfort care. She carries this baby to term. We deliver her most likely a little bit early via induction, so she would have a normal vaginal delivery. And we would make sure the baby was really comfortable. Baby would not be in any pain. Most likely there would be respiratory distress because of the pulmonary hyperplasia, but we would manage that. And then we would help her build these memories. We could do full intervention. We could put a breathing tube. We could do chest compressions and the whole gamut. We talked about all of this, and then we continued to talk about it. So I went weekly to see her and brought coloring books because she was like pulling her hair out. She was so bored, and just sat and chatted with her. Again, her husband was far away, so he wasn't with her for the majority of the time. So sometimes we had talks about coloring books, and sometimes we had real talks about what Dr. Paravicini and I had presented to her previously. Ultimately, she was being monitored in the middle of the night, and baby was bradycardic, so they rushed her off for a C-section. We had made a birth plan at that point, just in the case that she delivered, and it had indicated that she wanted full intervention. So she went to the OR, the baby came out, went to our transitional nursery. They did chest compressions, they did intubation, multiple rounds of epi, chest tubes, and still they couldn't get a heartbeat. So the neonatologist at that point called it, talked to mom, and eventually brought the baby to mom in recovery. When I walked in that morning, she had delivered probably a couple hours previously. The baby had become hydropic and was very difficult to look at. Was very swollen. There was like tape burns where the intubation tape had been. So it was really, really challenging. But the baby was shoved in a corner in the bassinet, and mom and dad were on the opposite side of the room. And previously, they had said that they wanted to do like a little photo shoot afterwards. So I had come in to take photos and to talk to them. And so Fran and I, who was one of the other nurses, we started to do this. And we picked Chloe up and talked to her lovingly and called her by her name and talked about how cute her little long skinny fingers were, and how much hair she had on her head, and all of these sort of beautiful, unique things that made Chloe special. And the family slowly started to be interested in touching her. So dad came over and took a picture with just the finger, and then mom said from the bed, "Oh, I want a picture of that." And from there, I was like, I know, we're getting there. And so we had a really beautiful afternoon, but I was really worried about her. It all had happened really, really quickly. But when I went in on the final day, she had decided to keep the baby with her for all 4 days that she was there in her room. She had like a little cooling cot, and she enjoyed every second. And I walked in and saw this picture. And dad was lovingly holding his wife, and she did not put down her baby the entire time. So what this story demonstrates is, again, this expertise, this prenatal consults, guiding her through what the baby might look like, birth planning, making it specific, resuscitation, and then this continuity of care where we continued to have this relationship. The mercy was modeling the behavior. She saw us and about how we looked at her baby, and we didn't look like we were scared of her baby. We told her how beautiful. We weren't lying. We said, "Oh my gosh, she has so much hair on her head. Oh, her fingers are..." We said true things, but we focused on the real beauty that this baby brought and not the painful entrance into the world. My mom makes homemade blankets for all of our families. So it has become a really powerful tool, which sounds silly to call a blanket a tool, but it is wrapped with a bow, And I go and bring it to families. And it's this like magical tool that immediately connects us to people. So I always say, this is my mom made this. And that connection of like my mom and your mom, and she made this for you and your baby. It's that connection. And it's also saying your baby is worthy of this. Your baby is worthy of this attention, of this love, of this dedication. And I see that, and I see that for you. We put the bigger the bow, the better on our babies. So especially on this baby when, it was so hydropic. Chloe was like really, really hard. So we used really large hats and bows to cover things as much as possible, obviously, and then photography. So that is the story of Chloe. And then I have one more story, and I'll go quickly on this one. So this is a Yamas family. This baby was diagnosed with Vactral, with left-sided multicystic dysplastic kidneys, right renal agenesis, anhydramnios since the second trimester, and multiple congenital anomalies. We met this mom really early, actually, probably around 18, 19 weeks. And she came in alone because her husband was a long-haul truck driver. So she was often alone. At the initial meeting, we sort of just talked about prognostic awareness. What have the doctors told you? Are you having a boy or a girl? Oh, how beautiful. Trust building, and making sure that she really understood what was going on with her baby and what that would mean, like long term, not just this is your baby doesn't have a right kidney and left one really doesn't function, but what that looked like. And then left it there. Didn't ask her to make any decisions, but built that relationship first. The second meeting, her mom came with her. Her mom didn't speak any English, but she, at that time, the mother of the baby told us that she felt like she really understood the diagnosis. She didn't want the baby to suffer, and she believed that a miracle would heal her baby, and that the baby would be born without any medical issues at all. I just want to stop here for a second and say that a lot of people in our realm feel like miracles are something to fight against. That because they believe in a miracle, that means they don't really get it. Oh, they don't really get it. And it's honestly, it's a condescending way to talk to people, to your patients. Did I believe that this baby was gonna be born with perfect kidneys? No, I didn't. But my telling her that her belief in a miracle was wrong or incorrect, that's not helpful in any way. So we weren't lying. We weren't saying, oh, you will have a miracle. What my line a lot of times was, I'm so glad that you have that miracle to continue to like hold you throughout this. And while we continue to hope for that miracle, how do you feel about making another plan in case the miracle that you are hoping for doesn't look like what we think it will? And she was really amenable to that. We weren't trying to disrupt her faith or challenge her faith in any way. Her faith was guiding her. Her faith was making this a more durable situation for her. So we made a second plan in case the baby came out and was not as robust as she was hoping for. The dad came after that at the next meeting, and it's really important in this situation that the dad was present because it's a real concern if one partner is not part of that conversation, because when they're in the delivery room, they could have questions they weren't communicated with as clearly. So dad came in native language. We assessed his understanding of the diagnosis, and he very much understood it as well. But we're just hoping we were wrong. And I always say, I hope we're wrong too. And I carry that with, I don't think we are. The scans are very, very clear. All of the information we have tells us this. But I would love if we were wrong. So At that point, she had a scheduled C-section. This was her first baby, but her MFM had told her that the best chance she had to see her baby alive would be to have a C-section. So that's what she did. And the baby came out breathing, but limp. And they handed me the baby, wiped the baby off, listened for a heartbeat, and then I just immediately put the baby on mom's chest and told her the heartbeat is really faint and she's still breathing, but she's very, very weak. And that was it. And then she didn't say, go save my baby. She didn't say, why are you handing them to me? Save him. She snuggled into this sweet little baby, and Dad held, and this was all in the OR, but they can do cheek to cheek. They can do lots of different things. And then we moved them to the recovery room. And as I was leaving the recovery room to sort of let them have some time alone, I heard them talk about the baby's pale skin and how he looked really different. And so I turned around and I said, would you like me to listen to the heartbeat, which I always ask before doing? And they said no. And it was a beautiful reminder that they are fine living in this world where they think the baby might still be alive, but we don't really know. They were just not ready to confront that yet. And that was perfectly fine. So they continued to hold. And this is a picture of them dressing their baby. Again, with this framework in terms of expert, we did prenatal consults. We talked about prognostic awareness versus alternative coping methods, birth planning, anticipatory guidance, delivery room management, which is a little complicated in this situation, and then continuity of care. In terms of Mercy, she had a lot of family that came and they all brought a different outfit. So we dressed her up in every single outfit. So every family could have a picture of the baby in the outfit that they gave them. So we did a lot of clothing changes. They got a Mimi blanket, it's my mom, photography. They bathed her, so she smelled really beautiful. She smelled like every other baby that you've ever smelled. And then we made suggestions. So this family particularly sort of didn't know what to do with themselves. They sort of were like deer in headlights a lot of the time, which don't blame them. So I made a lot of suggestions, would you like to do this or this? Would you like to do a bath, or would you like me to do the bath right in front of you? Do you want me to dress them, or would you like to dress them? Because I think sometimes families are so grief-stricken they can't even articulate. So by giving them options, we're facilitating the making of these memories in a way that's a little bit easier for them. And so I'll just end with a quote by Mahatma Gandhi that says, birth and death are not two different stages, but they're different aspects of the same state. So what seems like opposites, birth and death, in many ways are similar. And both midwifery and palliative care are rooted in this creativity and clinical skill, and the interplay is what makes this role unique and particularly powerful in this setting. Thank you.
Not sure I'm the best person to have moderated this talk as a mom of a 12-week-old, but thank you very much. It's okay, I'm very happy you exist and this program exists. Our next speaker, Emanuela, hopefully will be a little lighter for me. Emanuela Ciarlelli is the nurse manager of the operating room at the Jewish General Hospital in Montreal. She has been in a leadership and management role for 15 years, where she put in place many patient-centered initiatives that helped improve and optimize patient care and decrease length of hospital stay. She's currently known for a high recruitment and retention rate throughout the CIRUS, which is a provincial healthcare network here in Quebec. She is also a guest speaker at the Ingram School of Nursing, McGill University, where she completed her studies. As a graduate student at the school, she first learned about the strength-based nursing and healthcare, but only later during her career working alongside Dr. Lori Gottlieb, the founder of this program, was she able to witness its advantages in healthcare. Through her management role as a head nurse at the Jewish General Hospital, she has been able to implement this program both in the orthopedics division and now in the OR, the operating room, which she will tell us more about today.
So you can change with the arrow or with this one.
Okay. Good morning, everybody. Thank you. So my name's Otter. Can you hear me? I'm a little shy, so maybe that's why you can't hear me. It's not you. It's the microphone. Don't wait. Thank you. So my name's Emanuela Ciarlelli, and I'm the head nurse of the operating room here at the Jewish General Hospital. I'd like to thank the MedConference for asking me to speak. I'd like to thank Christina Benetti, who I worked very closely with, for giving me this opportunity to share what I've been doing at the hospital. So I will talk to you today about strengths-based nursing and healthcare, a way of being and doing to empower nurses in a hospital setting. So I would like to acknowledge the creator of strengths-based nursing and healthcare, Dr. Lori Gottlieb. She's affiliated with the McGill University. I would also like to mention that I have no conflict of interest to declare. We have no affiliation, honoraria, or monetary support from an industry source. I just want to mention that the implementation of strengths-based nursing healthcare is happening across many sites in Montreal. So there's an SBNH advisory committee, and then there's the SBNH clinical partnership group. So we are affiliated with the McGill University Health Center, the MOHC, Montreal West, and the Jewish General Hospital, which is the Centre Sud-Ouest. So a few objectives for the presentation. I'll define to you what strengths-based nursing and healthcare is, and I'll compare it to a deficit model. I'll explain the benefit of strengths-based nursing and healthcare, and I'll describe the how and the why I wanted to introduce strengths-based nursing and healthcare, and why I implemented it both in orthopedic surgery and the operating room. So SBNH is an alternative worldview to the deficit model. So in the deficit model, the healthcare provider is the healer responsible for fixing. In a strengths-based model, the patient's person are self-healers. The role of healthcare provider is to create conditions for healing. In a deficit model, it's very disease-oriented, deficit-based, it pathologizes. Where in strengths-based, it's very holistic, health-promoting, and experiences. In the deficit approach, it's all about the Ds: disease, deficiency, damage, defective, deficit, dysfunctional. And in the strength space, thank you. And in the strength space, it's more about the C's and the P's: courage, commitment, competence, capabilities, compassion, caring, choice, control, choosing, patience, power, and persistence. The deficit model we find is very paternalistic. There is a hierarchy of power concentrated in the provider. It's detached, it's the telling to, it's the fixing. Whereas in a strengths-based approach, there's a partnership. It's person, family. They find their own solutions with guidance. They're engaged. There's power sharing between the healthcare providers and the patients, because we both have our own expertise. And we learn from the patients and their families. In a deficit approach, it's more, what is the matter? But in a strengths-based approach, it's more, what is the matter, as well as what matters to you. There's more of a compliance approach in the deficit problem-based, whereas in the strengths-based, there's adherence, there's a negotiated approach that fits the person's situation, circumstances, and reality. In a deficit approach, it's more doing for, whereas strengths-based, it's doing with. And the deficit problem-based is more contextualized, whereas in a strength space, it's more contextualized, situated around the experience. So SB&H is about finding a balance. Humans are wired to see deficits. It's a mechanism of survival. There's a negativity bias. So we tend to store more negative biases than positives. And humans are also wired for strengths. Strengths needed for growth, development, thriving, optimizing, functioning, and connecting. And we can all be wired for positives. So just to recap, SB&H is, like I said, an alternative worldview to deficit model. It's, we're used to seeing healthcare professional as a healer, a hierarchical approach where power resides with the healthcare professional and patients, clients assumes a more passive compliant role. Focus on problems, weaknesses, dysfunction, deficits. Strengths-based, it's a patient-client self-healer and healthcare professional creates the conditions for healing. Healthcare professional shares power and patience. Clients become partners in their care. And we mobilize and develop strengths to minimize or contain that which is not functioning as well as to optimize functioning. So SB&H is both a philosophy and a value-driven approach. Philosophy, it compromises a set of related beliefs that influence the what as well as the how. A discipline and its practitioners should practice. It represents a purpose, a description, and a justification for the approach taken, and has a universal application. The values determine what is salient or relevant and what to observe for and what to ask about. Values guide our actions, that is context specific and fulfills a specific mandate. So what we want to really emphasize is that problems or deficits are just one part of the whole. So what is exactly strengths-based nursing in healthcare? It's a philosophy, it's a way of being, it's a value-driven approach, and it is an alternative worldview to the deficit model. What are strengths? Strengths are unique qualities of a person, capabilities that a person uses to cope, sources of power and energy that reside in the person. SB&H is an embodied practice. It is what we believe nursing to be. It is a choice, it is intentional, it is a way of being, think, feel, act, behave, and respond. SB&H is about acting with intention to provide SB&H care, attention, noticing and seeing the person, their inner and outer strengths, situated in different environments, and the reciprocal effects. Action, finding ways to capitalize, mobilize, develop strengths for healing by attuning, listening, skill training. Intervention precedes action. So how does strengths-based nursing and healthcare guide us? Strengths-based nursing aligns with the growth mindset rather than a fixed mindset. Challenges are considered opportunities for growth, not necessarily roadblocks. A strength-based lens looks for possibilities by examining assumptions and looking for variability. The person, issues need to be recognized that growth and change takes time. The word yet is an important part of thinking, or haven't achieved yet. So there's 4 pillars of the foundations of strengths-based nursing. So you have the person-centered, you have empowerment, you have relational, and you have the innate capacities. So the values, which I'll explain to you after this slide, are based on these foundations of strengths-based nursing in healthcare. So when we talk about strengths, when we talk about values, there are 8 values that we really focus on. So there's health and healing. Health is about creating wholeness, rallying. Healing is about recovery, repair, restoring wholeness. How do I contribute to my client's health, to their healing? Uniqueness. Every person and situation is unique. Who is this person? What are their strengths? What are their gifts? What are their qualities? Holism and embodiment. Everything is interconnected. How is X related to Y? How does the person experience, example, physically or emotionally? Subjective reality and creative meaning. Everyone may experience and interpret and experience the same event differently. What is my, and I cringe when I hear the word client as well, what is my client's understanding of X? People are trying to make meaning in a need to make sense of their experiences. What is my role in contributing to meaning-making process? Self-determination, decisions, choices, control, exercising agency. How do I contribute to my client's decision-making process? Collaborative partnership. Collaborative partnership is about sharing power and actively engaging in the change process. How do I engage my client in ways they want to engage? Learning, readiness, and timing. People learn best when they feel ready and the timing is right. What cues do I use as indicators of readiness to move forward? Do I consider time and timing? Person-environment integral. People are designed to be modified by experiences shaped and being shaped by their physical, relational, social environment. What do I need to consider to create a goodness of fit? Now, we had a patient, it was during the pandemic, so circa November 2020. And during that time, there were outbreaks and there were hot zones and there was a lot going on. We were tired, we were exhausted. We had this one patient. Now, at the Jewish General, on the west side, you have a beautiful view of the oratory. Have you guys seen the oratory? It's really nice. So we had a patient who, we had to change his rooms, we had to move his rooms for whatever reason, and he categorically refused to move rooms. Now, we were all in pandemic mode. He had to move his room because we had to do room changes, and he was a big roadblocker because he just wouldn't move rooms. So the nurse had gone in and she had asked him to move and he had said no. The assistant head nurse went in and he had said, no, I'm not changing rooms. So finally I went in, and I have to say, I didn't necessarily go in with a healing type of, approach because I really needed him to move. And so I walked in and I said, I was all business. I'm like, listen, you gotta move. You have no choice, da-da-da. And he's like, no. And I looked at him and I said, well, why? And I don't think anyone had asked him why. And he said, well, because look. And he's pointing outside and I see the oratory, the cross, but I see it every day. So for me, it was, okay. He goes, I'm not moving because of that. And I said, because of the cross. He's like, yeah. He goes, that's the only thing I have. Because it was the only thing he had. He couldn't talk to his family because he didn't have an iPhone or anything with FaceTime. Visitors' family wasn't allowed to visit. He had nothing. And I said, that's why you're not moving? He's like, yeah, that's the only thing I have. Every morning I wake up and I say a prayer. He goes, please don't move me. So I was like, oh, and I stopped and I said, wow, and I think what I take away from this story is you have to be intentional. You have to make the time to really ask the right questions. He wasn't trying to be, non-compliant. He wasn't trying to be a roadblock. That's the only thing he had. And he created meaning to his stale hospital environment, and that's all he had. So luckily, we looked for other solutions and we were able to keep him in that space. And every single time I walked by the room and I would peek in, because on an ortho floor, you get into the habit of always looking up in the rooms because patients fall all the time. And I looked and I would see him and he would say, you see, and he would always point to the cross. Now, fast forward 4.5 years later, my mom last week, she broke her hip. So she's on the same floor. And as I'm trying to get the surgery done in her room and I'm running around, she says, I have one thing to ask you. And I said, what? She goes, can I have a room on the side where I could look at? And I said, sure, Michael, yeah, okay, because I really want to look at the oratory. I'm like, yeah, no, that's good. So it just tells you that we all have our own values. We're raised a certain way. We have our cultures. We have a way of seeing things. So I see things one way, other people see things another way. And the basis of strength-based nursing is just to allow the patient and their families to express what they're feeling. And I think it was you had said the unrealistic expectations. It could be very hard, right? Because there are a lot of unrealistic expectations in the hospital. So it's hard to juggle that strengths-based approach where you want them to be part of the care, but also manage their expectations. So that was my story, my own personal story during the pandemic. So why SPNH? Because I feel SPNH is something that really resonates with me. I find it guides us, it empowers nursing, it broadens our scope of practice, and it's our nursing identity. I also feel that it empowers, you can't empower anybody, but you could create the conditions so that patients and families can empower themselves. So it's not what you look at that matters, it's what you see, right? He saw the cross. My mom is looking at the cross now. It's what they see that matters to them. What it's not, listen, it's not a model, it's not something you apply, it's not just a list of person's family strengths, it's not just about being positive, it's not a Pollyannish type approach. It does not ignore or negate or discount problems, and it's not prescriptive. Every single story is different, every single person is different. So this is the orthopedic department. Again, this is at the beginning of the pandemic when we still weren't wearing masks. And I took this picture because, it's really, we talk about strengths-based nursing and healthcare, but it's really, strengths-based nursing, healthcare, everybody. In this picture, there's pharmacists, OTs, PTs, there's physicians, there's nurses, there's orderlies. I wanted to capture everybody in this picture because it really takes all of us to run a unit and to take care of patients. So why did I think it was important to implement strengths-based nursing and healthcare in the ortho department? Because I wanted us to see the strengths in our patients. So, on a typical surgical floor, we do about maybe 600 joints a year. We do about maybe 300 or 400 hip fractures a year. So we have to hurry up and we have to discharge patients fast. So every day, Monday to Friday, for 15 minutes, we huddle. And during that huddle, we talk about, is the patient going home? Why isn't the patient going home? How come they're not going home? And so it is a very deficit-focused approach because we need the beds. So we have to sort of get the patients going. But during those discussions, it's very important to be intentional with your language. And it's also very important how you speak. Because patients sometimes and their families do have very good strengths that they want to bring forward, and it's within those strengths and us working with them that sometimes will get the patients out faster. So it's looking more deeply into their story, it's looking more deeply into the reason why, and that they can't necessarily just be discharged whenever we think they're ready to be discharged. So how did I do it? I'm very, very lucky to have had research students from McGill who, they're doing their graduate studies and they really want to do a project on a surgical unit. So, we introduced the approach through education. We actually developed these beautiful posters and we put them all over the unit. So even the patients, when they walk by, they look and they read it, and they also gain knowledge as to what drives our care. Right? What are some of the things we do for them? So, and some of the patients also ask questions. And I think it's really nice for them to see this because it takes into account them as a partnership in the care. So, we teach all the time, what are some of the things we could do with our patients to uncover their strengths? Well, there's questions for patients and families. How do you describe yourself? How do you describe your partner? What is working well for you for this particular situations? Or even for the nurse, like when the nurse does her self-reflection, what has impressed you about the patient or the family? Or which strengths need to be developed for this patient and the family? So how to uncover strengths? Well, active listening. it's not just hearing what they're saying, it's listening to what they're saying. And I find most of the time, we have a sort of cookie cutter recipe where we go in one room and then another room and another room because we have to get the job done. But it's really taking the time to listen to them. And you don't have to necessarily carve out an hour of your day. While you're taking the vital signs or while you're helping them walk, listening to what they say, because everyone has a story. Authentic presence, being there when you're actually there, not being on your phone, paying attention to what they're saying. Astute observation, and attunement. So now why the operating room? So I'm going to focus more of the presentation on this because I find it was very interesting. So for me to implement strengths-based nursing in healthcare on a unit was fairly easy, right? Because it's patient-centered, patient-centered, patient-centered. In the operating room, you have like 15 minutes with the patient, so and they're asleep, right? So how do you implement that? So I was struggling in my mind how to implement that in the operating room. Now another issue is that, not an issue, another thing that happened was that I was the head nurse of ortho for 14 years, and then the operating room was going through a very difficult time. They had just lost their nurse manager, and the culture, the climate of culture wasn't that great. So I was mandated to go to recruit and to retain and sort of help fix the culture. But I couldn't do that without having a good understanding of the actual culture. And then I realized something. I realized that I wanted them to see the strengths in each other. So I said, if I implement strengths-based nursing, there's so much good that all of them do, and they don't have the capacity to actually see it. So what we did was we created a little workshop where we began with the team leaders and we began with the assistant nurses. So every single specialty has a team leader. And I said, let's start with them and let's introduce strengths-based nursing and let them share stories. So we introduced the theory, we introduced the values, and what struck me the most when, they would say their stories, see, in ortho it was always stories about patients. Even I had a story about a patient. But when I was in the operating room, it was stories about themselves and how they saw surgery and what it did for them and how it made them feel. So that was basically the how. And during these presentations, I learned a lot about what speakers had said. And I wasn't going to share this story, but I'm going to share it because when we were all sitting together in the operating room, sometimes there's a big disconnect between the manager and the employees, right? They think that, oh, I'm the manager and I have no feelings whatsoever and I have to just set rules. But I wanted to show them that I also have a past. I also have feelings. And someone brought up burnout, right? About burnout and like sort of the higher ups having burnout. But I find that we need to talk about not just the burnout of work, but stuff that happens in our personal life, right? Because we're a different person to go to work, but I'm also a mom, I'm a sister, I have parents. So what about that and how that affects me? So my sister, 16 years ago, when I was 30, just told you my age, she was diagnosed with breast cancer. Now, at the time, so I'm Italian, so she had one type of cancer here, one type of cancer here, and she was under the age of 34. So at the time, they weren't testing us for any genetic mutation because they figured you're not Jewish, you don't reach all the criteria, you're not being tested. Long story short, we all got tested. And I was so, not ashamed, but when they call it a mutation, it almost feels like you're like an alien. Right? There is something wrong with us. And so for many years, I only told a core group of friends. I didn't tell anybody at work. Whereas my sister was like, she was bald, she was proud, everyone knew she had cancer, she would tell everybody, and it was her story. So she had a double mastectomy, she had no nephrectomy, she had reconstruction surgery, great. Fast forward 9 years ago. She came to my house and she had implants and she had said, I felt something on my implant. And I said, it's impossible. Like, she's like, nope. I went and I felt it, and I had a biopsy, and it's back. And I said, here we go again. So the same thing, she had removed her implants, same thing, she had chemo again, target treatment now for 2 years. And I had never dealt with that. So when I went to the OR, and this is where my story comes in. When I went to the OR, so usually we have a breast room every day, sometimes 2 rooms. I had said, okay, I am never gonna go into those rooms, ever. And if I have to, I'll just call in or something. And for a good 6-7 months, I managed to avoid those rooms altogether. And then one day I went in the wrong room. And I walked in, and I was like, and so at that point, I saw the patient on the table. But usually when they do a surgery, when you go in, sort of everyone's around the patient, so you can't really see what part of the body they're operating on. But for some reason, I walked in and I see the patient, and she was all exposed, and everyone's just standing around. And I felt like a wall hit me. But it was like, I saw the devil, like, boom, the devil. And I was like, oh my God, here I am. What am I supposed to do? So I turned to the team leader, who's so sweet. Her name is Kathy. I said, what's happening? Why is everyone like not working? And she goes, oh, we're waiting for the pathology. And she goes, and once we get the all clear, we could, close up or whatever. And I said, oh, and the phone rang when I was there. And I was like, great, we'll watch them say something like, oh God, but they didn't. So she hung up and she goes, okay, guys, it's all clear, which means that they had gotten all the tumor out and there was no more cancerous skin or tissue. And everyone started clapping. But everyone, like, oh, they're clapping. And at that moment, right, it was their compassion. They were so happy for this lady who they met an hour ago for a total of 5 minutes. And I felt as if everyone around the table, it was all like, they were all angels. And that moment that they had, that they were truly happy for this lady. And that for me was a very healing moment, because I had avoided those rooms like the plague. And for that to happen, and I also believe everything happens for a reason, was truly remarkable for me. So what are the benefits to the OR? The benefits to introducing strengths-based nursing to the operating room nurses: they had a better understanding of who they were. They had a better understanding of their values, of why they reacted the way they reacted. They connected on a different level. And during that process, when you tell a story, other people can heal from your story. So it's healing for you, but it's also healing for them. I feel it brought us closer together as a team. I feel like it brought me closer to them because I shared something with them, and I think I had never shared it with anybody else. So I think that was good for me, and that was also good for them. And now we're going to start implementing strengths-based nursing using the same approach with the other nurses. So just a brief summary. SBNH is an alternative worldview to the deficit model. It's a philosophy rooted in a growth mindset and 4 foundational and operationalized in 8 values that guide the nursing practice. SBNH is an embodied approach that becomes integral to one's own personal and professional identity. Any questions?
Sure. Yeah. Go down.
So anyone who would like to have questions, we can address them both Bryn and Emanuela.
I want to thank both of you because, oh my goodness, what great storytellers, what great presenters, and what really strong ideas. And so I'm taking notes and yeah. I think you kind of addressed, and you actually brought back some interesting memories with your discussion of the Fowler family. as a pediatric surgeon, I got called in one time for a family in a very similar situation, but where an obstetrician had decided that they would save the baby by injecting saline and had prevented the pulmonary hyperplasia, but there's, that's a bridge to nowhere, basically. And as a pediatric surgeon, I was called in as part of the group that was discussing this with family, and the consensus was to go ahead and put in a dialysis catheter. And this baby also had perforated into colonoscopy. And what happens is you end up in this path of, I think we're bringing them for 4 months to belong to bed, I for 2 days. Just multiple surgeries that broke my heart and gave me all the stress every turn. And that brought all that back and brought about how do we deal with those very complex situations where somehow we find line between all the ethics and what, not deciding for someone else, but their quality of life and well-being, and knowing an outcome that they can't see. And so I wanted them to sort of bear witness and tell me how much it resonated with me. And your presentation on stomach, that's like, I think it's very similar to the asset framing that I was talking about earlier. And I think that it is so powerful. And I had not actually heard the term before or seen those limiting principles. So thank you very much. I suspect I have another talk coming.
Transition.
Go great. I think the doctors are catching up with yours separately. What's he say?
Ways to go.
Thank you. I actually wanted to follow up on the prior comment because there was so much I learned about support people from what you described about our family, but I was honestly not working in that space, in the neonatal space, so that CPR was offered. And as someone who is sort of, I will use the word, forced to provide CPR in some really challenging situations, I wonder if you can speak to the healthcare workers and moral distress was just mentioned, in the efforts to support families. Was there discussion about what that was doing to the healthcare team as part of that?
Like, when is out there, yeah? Keep your child. Take it out.
So it absolutely was brought up to them. In our initial consult in which we talked about that, we certainly brought up everything, including using really descriptive words about what chest compressions are. And I think, Dr. Carchi can talk more about what that actual language is, but I think one of the things that was really hard for me to get to was, I think there's a difference between moral distress and feeling like you're torturing someone, and then a decision about where parents make a decision that you just disagree with. And there's a line between the two. Everyone is entitled to feel that moral distress that's going to rise, but I think it took me a long time, longer than I would like to admit, to get to that place where I wasn't judging families' decisions, even when I was really concerned about the choices that they were making. So did I think the resuscitation was the right decision? Absolutely not. But I think if you feel confident that they're making really informed decisions, that you feel like they get it, I think we have a responsibility to carry that out, even if we don't necessarily agree.
Yeah, I understand totally your question. So we live in a world where families have a direct contact with internet, and there are a couple of cases in the medical literature with babies who lived with diagnosis of renal agenesis. So that's why. So that's one thing. So that's why I want to say that we're aware that this option is available. But as she said, we give a description of what the baby look like, what the life would be looking like. But I think the most important point that we have with these families, we don't meet them once and that's it. The continuity of care and gaining their trust is probably the winning point, because at a certain point they will understand that we stand for them and for their babies. And for example, we can share stories of other families, we can meet them, they can meet other families. And also there is a lot of, there is a big problem with language, communication. I give you a case. I was called to see a woman, Spanish speaking, who came to the hospital in labor. She had a prenatal diagnosis of renal agenesis, and she wanted everything to be done. I was the neonatology on call, and so I went there. And I said with the interpreter, because I don't speak Spanish, "Mommy, tell me what's wrong with your baby. Tell me, what's the problem? What the doctor told you?" And she said to me, "The doctors are telling me that the baby has big problems with the kidneys." And so then I said, acknowledge, we had a little talk, and then at a certain point I said, "Your baby has no kidneys. The kidneys are not there." And at this point she started crying. She realized, and then we started the conversation about comfort care. We went to the comfort care. So it's also our little honesty that we have, or lack of honesty, in not naming things for what they are. Because she understood that there is no kidneys, there is no life.
It's very.
Oh, yeah.
Emanuela, thank you so much for the beautiful room with a view anecdote about the hospital. And I'm curious if you could share, if there's a way in which you distilled that experience of being curious about why do you not want to move as a takeaway that you carry into a kind of curiosity about patients generally who might be seemingly difficult or obstinate.
So I think what's important is you have to model the behavior, especially as a manager. And when I was speaking with him, I had other people in the room with me, so they saw how I spoke to him. And whenever we have situations like this, we always do a debrief after to talk about what happened, what did we do well, what could we have done better. And I use that way to really engage the staff and ask them different questions. I think it's an ongoing, I think it's not one particular example. I think all the time when you're dealing with quote unquote difficult patients, I think we always have to take the time to ask the questions. I find that a lot of times people, nurses, don't want to ask the questions. So then you have to ask yourself, why don't you want to ask the questions? What's it going to open, right? And then you have some nurses that will say, oh, it's on and on, I have things to do, and then, yes, but I find sometimes you have to have those moments where you really get an understanding of them. And I find also most of the time their understanding of what's going on is not good. So I find it's always good to ask them and to ask those questions. And I think it just takes practice.
So a couple of things. One of the things and I think you made the point about continuity and communication, which is so critical, right? You're taking people who are at one of the most difficult moments of your entire life. They're so vulnerable. And if it's a brief conversation, a big decision, none of us could do that either, right? in the case that I told you about the little lawyer, ended up operating, I think, 6 times. Before I got there, the question that was posed to the family was, do you want everything done? And we're all going, right? Oh, no, right? And the surgeon will be here because we've been putting on oath. And I had offered that guy 6 times before he died, because once you're down that road, you can't let it off so. And I knew I was hurting him. And it was all set up in advance by this question, do you want everything done? Well, there's no parents, there's no family members, so that's a crazy should be paying about. The other really important point that comes out of all of this sort of end of life discussion, there's a fabulous essay in several years ago in the New York Times called How Doctors Die. You are familiar with that? If you people are, you must read it, because none of us die in the ICU getting sick. Yeah. Okay. None of us. But yet that is what we are as patients. And I think that that's a very clarifying idea to help center us in how we have these conversations, what we would do unto others. It's that should not be often because we're not to ourselves well.
Yeah, we just had a training a couple weeks ago, and we had a whole thing about everything, do everything. Because we hear that we say a question and their answer is, I want you to do everything. Even if we're not the ones prompting it, we get it a lot. So what we respond with is, tell me what everything means to you. And then from there draw out, like, this family that we talked to said do everything, but they really felt strongly about not having a child with developmental delays. And they had a family friend that was basically attached to a ventilator, and what they said had a really miserable life. So that was like 7 questions down the road, but we got to a place where they didn't actually mean do everything. They meant, if you can give me him, this baby, with a life that I think is a life, then do all of those things. But if I am going to get a child that will be attached to a vent their whole life, that is not a child, that is not a life that I want. So it took a lot of questions, it took a lot of patience to get to that point, and then reminding them, I think we had this conversation with someone earlier, that reminding them of what they said they wanted to us when the baby got there. Because when a baby is born, what your response is, save my baby, do everything, save my baby. And then helping them step back and say, this is what you wanted, is that still the case? Giving people the option to change their mind, but really trying to unpack, do everything.
Thank you both so much.
You have to be just okay?
Sure.
Closer? It's just, there's a lot of you memories. I withdraw. Who likes people? What do to that? It's around sweet, so. Thank you. So I think similarly in the same vein of the answers you've given to the previous questions, one of the 8 values of the strength-based nursing and healthcare was assessing the family and patient's readiness to receive the information that will help them make those decisions. What are you specifically looking for from them that allows you to know, okay, now we can have this conversation?
So that's a perfect question. So I'll give you an example. So working in surgery, because we discharge them so fast, oftentimes they have to go home and they have to continue their care on their own. So we have to give their own injections, change their own dressings, etc. Now, what we tend to do is that we get to the point of discharge, half an hour before they leave, they're like, oh, okay, so this is how you inject, and if you look at them, they're not ready, no one's ready to self-inject. No one's ready to do that. You have to start the conversation before that point. So if you know that this patient is slated to go home, well then 2 or 3 days before, you know they're going to need to have some sort of injection, tell them. So, part of your course at home, you're going to have to be giving yourself these injections. How do you feel about that? Have that discussion first. And all the times it's, I can't. I want my wife or my son to be able to do that. And then you coordinate with these people. Have them come in, but have the same conversation. How do you feel about being able to give your father or your mother an injection? So I think it doesn't have to happen when we have the time. We have to put it within our plan of care so that we put it in earlier. So I'm a firm believer in that. And they're anxious. We call it, they're so anxious. It's having to prepare them ahead of time is going to, better the outcome of them actually doing well with their home.
Thank you.
MScN from Ottawa. I'm a general internist. Thank you both for your presentation, and thank you to everyone else who's spoken today. We've put some emphasis earlier in the day about the importance of words. We alluded to the potential pitfalls of using the term provider. We alluded to the term healer, which perhaps we reacted to in the back, but admittedly distinguishing it from a cure, or the one who provides cure. And here we were talking about the expression, do everything. So as a general internist, I of course do not deal with babies that are approaching death, but rather the elderly that very frequently do. And while there's a lot of education that remains clearly for many in the population around advanced directives, the one expression that everyone seems to know, and I'm sure everyone in the room knows, is DNR. And DNR is framed in a negative fashion, begging the answer, do everything. Because by suggesting it is what you're choosing not to resuscitate, we're clearly hinting we're not going to give them the full package. Do you want the full package, or do you not want the full package? And it takes a lot of, there are many steps to be taken then to kind of backtrack and frame things positively in what may be a much more appropriate, I think we all recognize this, a palliative setting, comfort-focused setting, for many of the patients in whom we clearly cannot be curers, though we can still be healers. And I just want to mention, there's a lot of things that came to my mind over the morning presentation, but just emphasizing this point, you talked about how at New York Presbyterian you are creating these narratives of what the patient's philosophy of care might be around the birth of their children, which clearly then does not fall in the trap of using acronyms that in fact mean nothing, because a DNR does not help me determine what we might do around intubation and use of pressors, and it's actually it's an empty statement which simply complicates any real and meaningful conversation, which anyway have to be titrated to the clinical context. So someone may have said DNR, but that does not help us in the moments for possibly totally reversible illness or possibly irreversible.
One of the other sort of words that we talk about is withdraw of care. So that's what, and we always say we never withdraw care, we redirect care, we think about care in a different way. And I think it's the same sort of thing with DNR, that we're not stopping doing everything, we're doing something different. We're prioritizing your comfort, we're prioritizing your death. We're celebrating this life until your death. But we're not removing everything, we're giving you something different. So trying to completely flip it on its head is what works best for us.
Lunch awaits, I think. Maybe in a couple of minutes. If there's no further questions, I guess we'll close the session and Alicia will tell us.